Hello, my name is Caroline Thirukumaran. I'm an assistant professor in orthopedics, public health sciences, and the Center for Musculoskeletal Research at the University of Rochester, New York. I'm a health services researcher by training. My research is at the intersection of health policy, orthopedic outcomes, and disparities in those outcomes. Today, I will be talking about the association of bundled payment reforms with racial and socioeconomic disparities in joint replacement surgeries. My work is funded by the National Institute on Minority Health and Health Disparities and by the National Institute on Aging. The plan for today. I will begin by talking about why total joint replacements, or TJRs, are a high priority cohort. I will then move on to what bundled payment reforms are all about. I will next discuss the mechanisms by which bundled reforms can influence disparities. I will focus on the comprehensive care for joint replacement model of 2016, which is a mandatory bundled payment reform and has been the focus of my research. In particular, I will focus on our recent 2021 study that examined the association between the comprehensive care for joint replacement model, or the CJR, and disparities in total joint replacement use. So to begin with, total joint replacements include both hip and knee replacements, and these are effective treatments for end-stage osteoarthritis. These are the most commonly performed in inpatient surgeries. About 1.2 million TJRs were performed in 2018. Medicare is the single largest payer for these surgeries, and TJRs are the largest surgical expenditure for Medicare. There is considerable variability in the use, outcomes, and spendings for TJR, despite their largely elective nature. Importantly, there are widespread, profound, and persistent disparities in both the use and outcomes of these surgeries. As recently as 2017, the rates of hip and knee replacements were 38 to 40% lower for Black Medicare beneficiaries compared to white beneficiaries. And as this is highlighted by the maps on the right, which represent the use of TJRs for Black beneficiaries, and on the left for white beneficiaries. The blue maps on the top are for hip replacements, and the green maps in the bottom are for knee replacements. And you will appreciate the stark color contrast, which represents the disparities in the use of these surgeries between white and Black Medicare beneficiaries. The sources of these disparities are multi-level, with patient, physician, and system-level factors contributing to these disparities. Now, moving on to bundled payment reforms. By bundled reforms, we mean reforms in which a single payment is made to, say, a hospital to cover the costs of both the acute and the post-acute care, or episode period. The length of this episode is variable and may extend from 30 to 90 days. The risk-bearing entity is generally a hospital, but it could also be a skilled nursing facility or other types of providers. Hospitals or other risk bearers may be rewarded if their episode spending remains below a benchmark price, or they may be penalized if their episode spending exceeds the benchmark price. Examples of bundled payment reforms includes the mandatory comprehensive care for joint replacement model of 2016, or the CJR, or the voluntary bundled payments for care improvement model of 2013. Payment reforms may influence disparities through the following mechanisms. First, they do not explicitly target disparity reduction. That is, they do not incentivize disparity reduction, nor do they report disparity-sensitive metrics. Importantly, because most of these reforms do not adjust for social risk factors, they have the potential to worsen disparities. And this may happen because racial, ethnic, minority, and low-income individuals are at a higher risk of adverse events and spending. Providers who care for them are not credited for the higher spending for these patients. Hence, providers are likely to exceed spending benchmarks and be penalized. Thus, providers are likely to be cautious in selecting socially disadvantaged patients for surgeries, thereby unintentionally worsening the disparities in access to joint replacement surgeries. With that background, we now examine the CJR in greater detail. Medicare's comprehensive care for joint replacement model was implemented in 2016. It is a bundled payment reform for hip and knee replacements. It is intended to improve the quality of care and spending for Medicare beneficiaries undergoing these surgeries. It was mandated for hospitals in 67 metropolitan statistical areas, or MSAs, in its original design. What CJR does is it sets a quality adjusted target price for a particular hospital, and hospitals that keep their spending below this quality adjusted target price are able to keep the difference in spending or earn that reward, and hospitals that exceed that quality adjusted target price are penalized or are required to repay Medicare the difference. The CJR was redesigned in 2018, where it changed from a fully mandated program to a part mandatory and part voluntary program. In 2021, the CJR was extended for another 3 years and was refined to include adjustment for social and clinical risk factors. What do we know about CJR's association with disparities? With respect to the use of total joint replacements, we know that the CJR was associated with reduced access to total knee replacements for Black beneficiaries, especially low-income Black beneficiaries compared to white beneficiaries. With respect to post-TJR outcomes, the CJR was found to have reduced readmissions for Black beneficiaries compared to white beneficiaries, and it has also reduced discharge to institutional post-acute care facilities. With respect to safety net hospitals, which are hospitals that care for disproportionate volumes of disadvantaged patients, safety net hospitals were less likely to receive rewards and more likely to be penalized in the CJR. In 2021, we examined the association of the CJR with disparities in the use of total hip and total knee replacement surgeries. The disclosures of my co-authors are listed below. The motivation for this study was that the CJR does not account or adjust for social risk factors. Hence, hospitals may selectively avoid the use of these surgeries for patients at risk of adverse outcomes or higher spending. This may limit access for racial ethnic minorities and low-income individuals and may ultimately worsen pre-existing disparities in the use of these surgeries. The objective of our work was to examine the association of the CJR with racial, ethnic, and socioeconomic disparities in the use of elective total joint replacements. We did this by accounting for the population of arthritis patients who are at risk or eligible for these surgical procedures. Our hypothesis was that the CJR would be associated with reduced probabilities of total joint replacements for non-Hispanic Black, Hispanic, and dual eligible Medicare beneficiaries compared to their counterparts. We used dual eligibility as a marker for socioeconomic status in our study. For this, we used the 2013 to 2017 Medicare enrollment, chronic conditions, and inpatient data. We included beneficiaries with arthritis who resided in the 67 metropolitan statistical areas, or MSAs, that were mandated to participate, or the 104 control MSAs that were identified by Medicare. The key outcomes of interest were separate binary indicators for whether a beneficiary underwent a THR or a TKR. We had 3 key independent variables. The first was whether a beneficiary resided in a CJR treatment or control MSA. The second was whether the observation belonged to the pre or the post-CJR period, with the pre-period extending from 2013 to 2016, and the post-period being the year 2017. A third key independent variable was a combination of the beneficiary's race, ethnicity, and dual eligibility. The race ethnicity groups of interest were non-Hispanic white, non-Hispanic Black, and Hispanic, and dual eligibility for Medicare and Medicaid was used as a marker for socioeconomic status, with dual eligible beneficiaries representing those from the lower socioeconomic strata and non-dual eligible beneficiaries representing those from the higher socioeconomic strata. The covariates of interest included age, sex, chronic conditions, and the year of the observation. To address our research question, we used a triple differences estimation approach, where the first difference is the pre and the post difference for each patient group of interest. Difference 2 is the difference in difference 1 between the CGR treatment and control MSAs, and difference 3 is the difference in difference 2 for each patient group of interest compared to white non-dual eligible beneficiaries. And here are our results. Our study included observations of about 4.4 million beneficiaries. Their average age was 77 years, 66% of them female, 88% white, 14% were dually eligible for Medicare and Medicaid. The rates of hip and knee replacement were 1% and 2% respectively. Examining the trends over time, the graphs on the top are for THRs, with the graphs from the left to the right representing THR usage for white, Black, and Hispanic beneficiaries. The orange lines are for non-dual eligible beneficiaries, and the teal lines are for dual eligible beneficiaries. The solid lines are for those residing in CGR treatment areas, and the dotted lines for those residing in CGR control areas. There are three key impressions from this picture, with there being a substantial gap in use within each racial group for dual eligible and non-dual eligible beneficiaries. The second is that the highest usage of these surgeries is for white non-dual eligibles, followed by the Black non-dual eligible surgeries. And importantly, if you note the middle panel of the bottom row, you will note after the implementation of the CGR in 2016, there is a dip in the usage of total knee replacements for Black beneficiaries, as noted by a downward decline in these lines. These are the key findings from the multivariable models. I will focus on knee replacements because this is where we found our significant findings. The dark bars represent the change in the use of the TKRs with CGR implementation. There were significant increases for white non-dual and dual eligible beneficiaries, and significant declines for Black non-dual eligible and dual eligible beneficiaries. There were no significant changes for Hispanic beneficiaries. The light bars represent the change in the usage of knee replacements compared to white non-dual eligible beneficiaries. That is the triple differences approach. And as you will appreciate from this graph, the use of total knee replacements for Black non-dual eligible and Black dual eligible beneficiaries significantly declined compared to white non-dual eligible beneficiaries, indicating that there was a widening of the gap between these patient groups or a worsening of disparities. Overall, the CGR was associated with 7% to 19% fewer TKRs for Black non-dual eligible and dual eligible beneficiaries, respectively, compared to white non-dual eligible beneficiaries. And now moving on to the discussion. CGR, one of the few reforms using a random assignment, was found to be associated with modest reductions in TKR use for Black non-dual or Black rich and Black dual eligible or Black poor beneficiaries as compared to white non-dual eligible beneficiaries. This widening of gap is superimposed on pre-existing disparities. No evidence for change in THR use disparities were found, and no evidence for change in the use of these surgeries for Hispanic beneficiaries was found. The study has several strengths, including that we focus on the race, ethnicity, and dual eligibility combination. There is a separate focus on THRs and TKRs, and we account for the beneficiaries who were eligible for these surgeries or at the risk for these surgeries. And we also control for several chronic conditions. The limitations of this data include that we use administrative data, and hence clinical factors such as arthritis and arthritis severity and type cannot be controlled for. And finally, moving on to the implications. Our study generates empirical evidence for concerns raised about patient selection. There was a worsening of disparities for TKR, and this was likely due to the greater need for institutional rehab higher adverse events, and longer recovery period for TKRs compared to THRs. This also raises the concern that other payment reforms with limited risk adjustment may further worsen disparities in use of these surgeries. Thus, there is a need for risk adjustment for clinical and social risk factors, for metrics to incentivize disparity reduction, and for the reporting of disparity metrics. In its recent 2021 extension, the CGR has included a risk adjustment of the target prices for clinical factors such as age and the hierarchical condition category score, but more importantly, it has also included risk adjustment for social risk factors such as dual eligibility, which is a step in the right direction. This brings me to the end of my presentation. Thank you for your interest in this work. I'm happy to take any questions or comments.